We will continue with the next lecture. Up next, we have another fantastic session, and it is my privilege to introduce and call our next distinguished speaker, Dr. Sharad Deshmukh, sir. He is senior consultant, internal medicine and diabetologist at Midas Hospital, and he'll be speaking on management of hypertension. I would also like to call upon Dr. Saurabh Rokade, sir, Dr. Sudhir Safre, sir, Dr. Debashis Bara, sir, to chair this session.
Good afternoon, everyone. The next topic is the treatment of hypertension. And to present this is simple but one of the most complicated treatment part. We have got none other than the eminent physician, Dr. Sharad Deshmukh, sir. Everybody knows about him. One of the senior most physician and basically backbone of all scientific program of this CME. Sir is the one who is framing all this program. So over to you, sir. Yes, sir.
Well, thank you, Sudhir. What I'm going to speak about in the management of hypertension today is in 15 minutes, is what the recent guidelines have to say and what they have to emphasize, and the routine management which we have. Now, if you want to know what is hypertension, we know for certain that there is a continuous identified incremental risk of CV disease, cardiovascular disease, stroke, renal impairment, and dementia at the level above 120 and 75. Some literature says 115 by 75. And if you look at the data of HOT study is hypertension optimal treatment data, which was published in 1995, what they have shown is every 2 millimeters increase in diastolic blood pressure is associated with increased cardiovascular risk. Every 4 millimeters from 85 to 89, there is an incremental risk. So meaning thereby that these numbers have definitely very important meaning. It has also been shown that lowering systolic blood pressure by 10 to 12 millimeters and diastolic blood pressure just by 5 to 6 millimeter causes relative risk reduction in 5 years in strokes to the tune of 35 to 40%, CHD risk, and about 50% less risk of the heart failure. So based on these guidelines and these observations, in 2017, ACC, that is American College of Cardiology, and AHA guideline came. Now, these guidelines based on what is called as a sprint trial, which I'm going to tell a little later. What it says is that hypertension, anything above 130 millimeters systolic and above 80 diastolic, is a stage 1 hypertension. And stage 2 hypertension is, they're very strict about it, that it is above 140 millimeters and or above 90 millimeters should be considered as hypertension. Now, if you look at these data, that means this classification, then there is so much increment in the epidemiology of hypertension in the masses. As against that, to confuse it further, in 2023, Europeans have given their own guidelines. There is a European Society on Hypertension. What they have said is they defined hypertension as above 140 millimeters systolic and 90 millimeters diastolic, and then subsequently grade 2 and grade 3 hypertension. So these are two guidelines. So these guidelines, basically European and American guidelines differ, that Americans say that it is 130 by 80 and above that is a high blood pressure. And the European guidelines, they say that 140 and above and 90 and above is hypertension. However, these guidelines, they accept, they have something which is very common, that the targeted blood pressure after treatment is 130 by 80 in a large number of population of hypertension. Most of the hypertensive population, they fit between 18 and 64 years. And the targeted blood pressure is 130 by 80, no matter even up to the age of 80, the recommended target of blood pressure is not below 140, and 90, but it is below 130 and 80. Right? Now, these guidelines have given a lot of importance to the way we measure blood pressures. And most of us and most of the clinics, we don't follow these guidelines, and these are the guidelines which they have used in the research settings. What they emphasize is that there should be a very accurate BP measurement, and office-based BP measurement is very important versus the home, because most of the trials, most of the research studies have taken office-based readings for deciding the numbers on which the research has been based. The blood pressure apparatus which you are using or your patients are using at home should be well validated, and you should encourage the home readings as well by way of ambulatory BP monitoring, ABPM, or sometimes you can ask patients to buy digital equipments to keep their record, because home blood pressures at times are quite lower and the office blood pressures are quite higher, and there could be discrepancy in the two readings. And there is something called as a white coat hypertension, wherein the blood pressures in the clinic are higher and the home blood pressures are lower, and we know for certain the incidence of which is about 15 to 20%. That is there is a large number of patients have white coat hypertension. Masked hypertension is a variety where home readings are higher and office readings are normal, and this also happens at times that patients come and say that, doctor, my blood pressure at home is higher, but you are telling me that my blood pressure is normal, and its incidence varies from 10 to 30% in various trials. Now remember, white coat hypertension, the CV outcome is same as normotensives. But masked hypertension must be treated because CV outcome in these patients is, for that matter, any patient who has got established hypertension. In borderline cases who have stage 1 hypertension or a grade 1 hypertension, please do, if you are not sure about the blood pressure, whether a patient has white coat hypertension and you are not sure whether he has blood pressure, always make use of the ambulatory blood pressure monitoring, which keeps records every half an hour, and you get an average 24 hours reading, average daytime reading, average night. So this make use of ABPM whenever you are in doubt, because it gives a very relevant data. As far as the treatment is concerned, all the guidelines have given a lot of importance to lifestyle interventions based on these 6 criteria. Salt restriction, DASH type of diet, that is dietary approach to stop hypertension, regular exercises, weight reduction, alcohol restriction, and high potassium in diet. DASH diet, which is based on fruits, vegetables, and low-fat dairy diet, in DASH trial, they have shown that there is a significant, this is just 6 weeks trial, they have shown that there is a significant reduction in the blood pressure who are not following this in this trial, with this diet. So this diet is very important. So this must be advocated, because if patients follow the lifestyle interventions, then you can virtually reduce 1 medication for treatment of hypertension. As regards pharmacological agents, some of the most important drugs which have been prescribed by the guidelines is, number 1 is diuretics, which we very commonly use. The thiazide group of diuretics and the drugs which are similar to thiazide group of diuretics, that is chlorthalidone, they are very good drugs. They are very useful for elderly hypertensives and they are very effective. They should be used in low dose because they have some important metabolic side effects which become less if you are using low dose, and they are very effective. In ALHAT trial, it has been demonstrated that they are better than ACEIs, ARBs, and even calcium channel blockers as far as the CV outcome is concerned. So you have to trust this drug in most of the patients, particularly in the elderly class of patients. Loop diuretics, please don't use them in patients with hypertension unless they have a compromised EGFR, they have a renal dysfunction, or patients have congestive cardiac failure. And the non-selective aldosterone antagonists like spironolactones, they are useful drugs, particularly for a patient who has got resistant hypertension. Resistant hypertension itself is a topic by itself, but if you find that the patient is not adequately responding, make use of aldosterone antagonist, that is spironolactone, and you may get the desired results. RAS blockers, we use them left, right, and center almost every day, ACI as well as ARBs. They are wonderful drugs as antihypertensives. Their advantages, they can be combined with a calcium channel blocker, they can be combined with a diuretic, they can be combined with a beta blocker in order to enhance their efficacy. And they have one particular effect on the kidneys, that they can reduce proteinuria irrespective of their antihypertensive potential. But beware that there are important side effects as well. Be aware of hyperkalemia because of hypoaldosteronism they cause. Second is that these drugs can cause renal impairment, particularly for patients who have a bilateral renal artery stenosis. Bilateral renal artery stenosis is not uncommon in elderly class of patients because they have a atherosclerosis of the renal arteries, which may not be at the ostium of the renal arteries, but may be in the branches of the renal arteries. And you will be surprised that no sooner you start a RAS, say enalapril or losartan or something, and the patient's creatinine starts going up. One has to follow a caution that anything which reduces the blood pressure or which causes dehydration like vomiting, diarrhea, hypertension, or for that matter a patient who has got congestive cardiac failure, there is a likelihood that these drugs can cause renal impairment. And that is why its use is very important. And in a patient, particularly in patients who have non-steroidal anti-inflammatory agents being used simultaneously, always ask your patients to stop ACI or ARB for a few days. CCBs, calcium channel antagonists, they are very good drugs, nifedipine, amlodipine, diltiazem, and there are new additions like cilnidipine and benidipine and so on. And there is a lot of literature available, and the advantages being focused. We still don't know whether how benidipine and cilnidipine is more advantageous as compared to amlodipine. But then there are drugs which can block all the three the channels of calcium inflow, that is L channel, N channel, and T channel. They are very good drugs, and they can be combined with ACIs, they can be combined with beta blockers in order to control the blood pressure to the target. Beta blockers, they are again very good drugs, but then they should be used only preferably in patients who have already established coronary artery disease, either in the form of angina, or a patient who has already sustained a myocardial infarction, or a patient who has got a compromised LV dysfunction. But then the beta blockers are not indicated for the primary prevention because most of the trials have shown that beta blockers, they are inferior as compared to calcium channel blockers, ARBs, ACI, and chlorthalidone in reducing the CV events. Alpha blockers, they are good drugs for achieving the target of blood pressure, but then they are inferior in reducing the CV mortality and morbidity, as has been emphasized by Al-Had trial where doxazocin was used and was found to have increased incidence of CV events. So what is the choice of antihypertensive drugs which you should go ahead? All drugs are equally potent, not that ACIs are more potent as compared to diuretics and so on. All drugs are equally potent. They usually reduce blood pressure to the tune of 8 to 10 millimeters. But usually younger patients with hypertension, they respond nicely to ACIs and ARBs and beta blockers. Older patients, they respond better to CCBs, diuretics, and CV protection is equal with ACI, CCBs, and diuretics. There is a less protection with alpha blockers. Beta blockers are by and large considered inferior in CV protection, strokes, and prevention of renal failure. So they should not be the first drug of choice, as I said earlier as well. If a patient has diabetes, make use of ACI because it reduces proteinuria. That is a distinct advantage. And ACI, ARBs, they are included in the protocol because they retard the progression of renal disease in the setting of diabetes. The SPRINT trial is virtually a landmark trial which has shown for the first time that intensive control of blood pressure, where systolic blood pressure was targeted below 120 millimeters versus a standard control where a systolic blood pressure was targeted between 130 and 135 and 139. In intensive control, there was a 25% less events in the mortality, and that was a big achievement for that, and that is why the guidelines have changed. Now, what is the goal? What is the target? A patient, any patient where we are using blood pressure treatment for secondary prevention of cardiovascular disease, meaning thereby that a patient already has angina, or a patient who has an old myocardial infarction or a stroke, BP goal is below 130/80. For a primary prevention, always be in a habit of finding out the ASCVD risk score, and if it is more than 10% in 10 years, it is a primary prevention. The goal is 130/80. If the patient is a diabetic hypertensive, the goal is below 130/80. If the patient has hypertension, CKD and hypertension, the goal is below 130/80. Only elderly people who are supposedly have a limited life expectancy, you could be more liberal about keeping that. So in summary, as far as when you are treating hypertension, treat numbers, not symptoms, because all the guidelines have targeted the numbers, and these numbers are useful, beneficial, that has to be kept in mind. All the guidelines have emphasized and re-emphasized that your blood pressure recording habits must improve, and this can be discussed at length, and therefore one can only say that you should improve your blood pressure measurement habits, make use of ambulatory blood pressure monitoring, encourage patients to record blood pressure at home. Always you should have a ASCVD risk calculator app on your mobile, and avoid physician inertia. If the patient's blood pressure is 136 and your targeting is below 130/30, then you should not take time to increase the dose. That is what is called as a physician inertia. Most of the guidelines have given importance to physician inertia, and that is probably very true. So this is my last slide. Thank you very much for a patient listening. Thank you very much.
As always, sir has not left any stone in comprising the hypertension and giving a comprehensive, thorough idea about the hypertension management. Hats up to you, sir.
Thank you. Thank you.
Any questions from audience?
Sir, one more question. You mentioned alcohol restriction, male 2 drinks and female 1 drink. Why so?
Why so? Now, there are guidelines as to what is the safe drinking level. And that is mainly targeted for liver disease, that is alcoholic fatty liver disease. And in the guidelines, that 90 ml is permissible limit daily for males, and 45 ml per day is permissible in females, because anything which exceeds that increases the risk of fatty liver disease in these groups, and there is a gender difference.
Thank you, sir.
Thank you.
Sorry? Is there a safe, this is a safe limit of alcohol drinking. This is a safe limit of alcohol drinking, and this is more or less accepted level of, and each drink is of 45 ml, right? So you can, for those who regularly take alcohol, it is permissible up to 90 in males and up to 45 in females.
Good afternoon, sir. Sir, is there any drug threshold level for chlorthalidone, above which patient is likely to develop electrolyte imbalance, particularly hyponatremia.
Hyponatremia, yes. You have to always keep in mind that there are some important metabolic side effects of thiazide and thiazide-like drugs, and they can cause hyponatremia, hypokalemia. But then for chlorthalidone, hypokalemia is very important. Of course, it can cause hyponatremia. And the lower the dose which you use, and the recommended dose is 6.25 to 12.5. Now, earlier on, the recommended dose used to be 25 milligrams and 50 milligrams, right? So, hydrochlorothiazide as well as chlorthalidone were used in that higher dose. But subsequently, what we realized was that the lower doses work equally well. So, 6.25 is a more acceptable dose. You have dose-related less side effects, and it is equally active. It is equally active. It works by itself because by initially causing natriuresis, but then subsequently it causes vasodilatation. So all of that effect on the blood vessels is achievable with even 6.25 milligrams of chlorthalidone. And second is that it causes, by reducing the blood volume, it causes hyperreninемia. And then if you combine it with a ACEI or ARBs, you potentiate the effect of ARBs and ACCI. So you have two drugs which are acting in a very different ways. They potentiate each other's action. So that's the way to go about it. So you use a lower dose, you get lesser side effects. But then you should always be watching the sodium potassium levels whenever you are using these drugs.
Thank you, sir.
Yeah.
Sir, at what time we use the diuretics, morning or evening?
You should be using it in the morning.
So I want to ask if patient is already on triple therapy for antihypertension and still BP is not controlled, how do we proceed further?
Well, if you are using 3 drugs, one of which is a diuretic, right?
Yes, sir.
And if the blood pressure continues to be above 140 and 90, you call it as resistant hypertension.
Yes, sir.
The most common cause of resistant hypertension is poor compliance by the patient. So always interrogate the patient, whether he or she is taking the drugs properly. Second important condition is obesity. So you should work on obesity, diet, exercises. The third thing, that alcohol is a very important contributing factor to making the hypertension resistant. There is a linear relationship between alcohol dose and hypertension. What you understand by linear dose means as the alcohol increases, the blood pressure increases, and you have a straight graph, right? So that has to be looked into. And the fourth factor you should be looking into is that most of these patients have what is called as PA. PA stands for primary aldosteronism, irrespective of whether their potassium is normal. They can have primary aldosteronism. Incidence of primary aldosteronism has been found to be 22%, and if they have a resistant variety of hypertension, even up to 40%. And that is why the role of aldosterone has come there.
So
the fourth drug is aldosterone.
Thank you, sir.
Slides, you have shown that you should not use diuretics along with calcium channel blockers.
Yeah.
But we use all 3 together, ARBs, calcium channel and diuretics.
Yes.
So what is your take on?
Yes. So when you are using it in 3 drugs, you are using it with either losartan, telmisartan, or you are using it with ramipril or enalapril. So there is a definite advantage using ACI, ARB and a diuretic because, as I said earlier, diuretics increase the renin levels. And when you block renin levels, you get more potentiated action of ACI and ARBs. But if you are combining calcium channel blockers and diuretic, then there is no decrement in the level of blood pressure, nor they have been proved to be beneficial in reducing the cardiovascular events. And that is why you don't see combinations of a diuretic and amlodipine being marketed. So it is controversial, and it has not been proved that it really works. But the third drug has to be there, which is either a beta blocker or it has to be a ACI or ARB. That is why. But if you are deciding to use, say, amlodipine, and your second drug is chlorthalidone, then it is not a good combination.
Thank you, sir. Thank you for your master presentation.
Well, thank you very much. Thank you.